Thank you.
Like Sudha madam, Jyoti also does not need any introduction. It's up to you.
So, with your permission, may I start my session, please? So, once again, I will like to say that Estella has supported us for uh, information regarding the new things which are there for the therapeutic advancement of VMS, because VMS is the most predominant pronounced symptom of menopause issues. मेनोपॉजल सिम्टम्स बोलने से ही समझ में आता है कि वीएमएस की बात सबसे पहले हो रही है. And when it is a matter of MHT or something else, lifestyle modification, etc., then lifestyle modification बोलने में सुनने में बहुत अच्छा लगता है, करने में बहुत दुखता है. So, and for MHT, every patient is not fit for taking that, and many of them are not basically from their mind ready to take that. Even the doctors to prescribe, they are a bit hesitant. So, what other options we have with us? So, let us know about that. And this education from Estella Pharma, this educational session is from them. So, we'll discuss today about the overview of non hormonal option and recent therapeutic advances, including NK3 receptor antagonists. So, we'll focus mainly on that. The rest of the part we'll not discuss because in the lifestyle modification workshop and other lectures, those things are being covered. So, let us go through the evolution of management of options for VMS associated with menopause. There are prescription therapies and there are non prescription therapies both. The prescription therapies include hormone therapies, estrogen alone, estrogen with progesterone, estrogen combined with selective estrogen receptor modulators. Some non hormonal therapies like SNRI, SSRIs, and few antidepressants, antihypertensives, gabapentinoids, anticholinergics, antimuscarinics, and the new addition is neurokinin 3 receptor antagonist. In the non prescription therapies, as we have discussed a bit and will discuss tomorrow about the lifestyle modification, exercise, dietary modification, cooling techniques, weight loss management, yoga, etc. There are mind body techniques also which can help us: based respiration, clinical hypnosis, mindfulness based stress reduction, and cognitive behavioral therapy. And mind it, the cognitive behavioral therapy लिखने से समझ नहीं आती है that what is this CBT. It is really very effective. Interpersonal relationship, how we have to behave, how we have to cope up. This CBT works a lot. Traditional medicine remedies and other treatments like Chinese medicines, herbal supplements, phytoestrogens, stellate ganglion block, acupuncture, so many things in our basket. So let us see that when we can give what and what are the various contraindications for the menopause hormone therapy, which is the first line therapy for the management of VMS. But there are so many limitations too. What are those limitations? The contraindication. If there is a personal history of breast, endometrial, or other estrogen dependent cancers, established risk for CVD, previous venous thromboembolic event, or stroke, transient ischemic attacks, etc., active liver disease, unexplained vaginal bleeding, at high risk of breast cancer, the women, it is already on a higher side. The risk factors are increasing and we are no less behind. So we need to see about the whole history of the family, their own history, and then we can only go for think about the prescriptions. So after managing all this, seeing all these contraindications, it comes in our mind that what next? There are few relative contraindications also which are not absolute one, like uncontrolled hypertension, dyslipidemia, migraine, and few more. So in that condition also, maybe it is not the first choice of the patient or the doctor. There are some clinical challenges also associated with menopause hormone therapy. Everything comes with something good and something bad. So when we give MHT, there may be because of progesterone, breast tenderness, fluid retention, nausea, breakthrough bleeding, because of estrogen, endometrial hyperplasia, fear of breast cancer, refusal of MHT can be there, pre-MHT workup, compliance and follow-up can be an issue also. So when HT are contraindicated, what is in our basket left? Tibolone, phytoestrogen and non-hormonal drugs. So, see, Tibolone is not exactly, will not say MHT, but basically it is MHT like. Tibolone is also working on the same pattern and same receptors. So, Tibolone, wherever the MHT is contraindicated, in most of the cases, Tibolone is also contraindicated. Phytoestrogens, there is no particular regulation about the amount of the phytoestrogens, and phytoestrogen also carries the estrogen. So, unopposed, very, very prolonged usage of estrogen is also not, phytoestrogen is also not recommended. Non hormonal drugs. Let's see. The NAMS come up with its recommendation. The summary of NAMS guideline I have proposed here. So, the level of evidence, level 1, you can see that NAMS statement, that is the North American Menopause Society statement guidelines, says that CBT, clinical hypnosis, shown to be effective in VMS, paroxetine, fazolinetant, are the only FDA approved non hormonal medications for VMS. Other SSRI, SNRI, pregabalin, clonidine, oxybutynin, which are also recommended but they are non FDA approved. Gabapentin is also not FDA approved for VMS indication but it is being used. So these medications can be used. They are recommended as level 1. Rest all, paced respiration, clonidine, uh, not recommended for, along with the due to adverse effects, and wash is also not recommended. Similarly, the weight loss and stellate ganglion is recommended. Even the small amount of weight loss, 2 kg, 4 kg, that also affects your lifestyle and the good effect occurs at the VMS as well. Stellate ganglion is effective treatment but not very commonly opt for. The rest things are basically just a supportive management, but you see the significant statistical difference in the VMS incidence earlier and later after the cooling technique, acupuncture, or the soil treatment, dietary supplement. This is actually not significantly difference when you see the studies and research. So these things are not recommended much. So, once again, reiterating the status of non hormonal options in that SSRI, SNRI, selective reuptake inhibitors, they are associated, they are effective, but they are associated with mild to moderate improvement in VMS. These medications are very good when the depression is one of the predominant factor along with VMS. So it works on both. And the side effects which are associated with sedation and all can be tolerated. Paroxetine and fluoxetine are not recommended after breast cancer as they affect tamoxifen metabolism. So very cautiously we have to see that what medication we are giving. Gabapentin is associated with improvement in frequency and severity, but the main problem is again about the sedation. So the patients who are not having the problem with the insomnia, only in those patients gabapentin is okay. Otherwise, gabapentin gives a very bad sedation. Oxybutynin is basically because of the associated cognitive decline in the long term use. It is basically not much recommended. Pregabalin is not recommended for VMS with the because of the adverse side effect. Clonidine is not recommended nowadays because of the side effects. Neurokinin B receptor antagonist, we have few in bucket like fazolinetant, alinzaninetant. They are not in the market right now in the India, but they are on the way, especially the fazolinetant. But in the rest countries, fazolinetant is being used since long time, and alinzaninetant is coming recently. Current preferred treatment in the Western world for VMS, only VMS, is are these drugs. So, vasomotor symptom and the thermoneutral zone, very nicely explained about the vasomotor symptom by Sudha madam. So, not needed to say much, but it is definite that there is a contraction of the thermoregulatory zone there, whereby a bit of the increase of the temperature or decrease of the temperature gives a hot flashes or the shivering because of that particular mechanism of lowering of the narrowing of the thermoregulatory zone. So, how this shivering or hot flashes occurs? What is the mechanism behind that? There is one neuron known as KNDY neuron, which is basically supplies the hypothalamus, and when the two arms of a seesaw is well balanced, like NKB receptors and estrogen receptors, everything goes well. When one arm is upside and another arm is downside, like estrogen arm is downside, and so then the second one becomes the stronger. So NKB receptors becomes very stronger. They make these neurons hypertrophy. They stimulate continuously stimulate to the hypothalamus, and the normal cooling phenomena which should be done, it is not done. So normally the dissipation mechanism characterized by sweating and peripheral vasodilatation are triggered in response to change in temperature. But when the you can see here the estrogen is very less and NKB is high, so the woman is, whenever she is having increased activation of heat, the heat dissipation is giving the hot flashes. There is declining estrogen levels in NKB. KNDY neurons becomes hypertrophied and alters signaling in the thermoregulatory center, shifts the balance from control of core body temperature and activates heat dissipation, effectively resulting into the VMS. Then when we know the mechanism, so what we can do about that? कारण पता है तो समाधान निकालना है. कारण अब हमको पता है NKB are the problems. So NKB receptor antagonist, can they help? So basically, these NK3 receptor antagonist, they suppresses the NK3 receptors, and so the thermoregulatory zone is also comes in balance, and restoration of the set point of control of core body temperature reduces frequency and severity of the VMS. So this is new therapy which results in the highlight of the utility of fezolinetant as an effective treatment option for those who have contraindicated to or choose not to use hormone therapy. There are few more things also in the basket apart from the fezolinetant and elinzanetant. While making this chart, you can see the fezolinetant blocks the neurokinin at the NK3 receptor, and elinzanetant blocks at NK3 and NK1 receptors, and it reduces the thermoregulatory dysfunction, and NK1 improves the sleep also. So when there is a problem with sleep, then only the elinzanetant is specifically recommended. MLE 4901 is its development is limited to the liver toxicity concerns. That's why it is not in the much ahead in the studies, and the the um, newer other things like pevinitent, the early clinical studies shows symptom reduction. So just now the clinical studies are very less and it is comparatively new thing. So see, the fezolinetant is well studied molecule. We have skylight 1 and skylight 2 studies in which the 45 milligram of fezolinetant once daily improved sleep, and the onset within 1 week is shown, and skylight 4 shown the long term safety and tolerability also. So with the other medications, the long term safety are not yet seen because they are not in the market right now for from the long time, but fezolinetant yet not shown any very important side effects, but it is well tolerated also and giving very good results in the moderate to severe VMS. These are the study numbers which are registered in Skylight 1 and 2, and they are published in Lancet, like fezolinetant treatment to moderate to severe vasomotor, published in Lancet and also in the Journal of the Clinical Endocrinology and Metabolism. And both studies suggested they that they are improving the, uh, they are helpful in the management of the moderate to severe VMS. There is long-term study of 52 weeks, and with follow-up of 3 weeks extra, total 55 week study for Skylight 4 is also there, and it is also suggesting that there are no significant side effect affecting any women's life. For the safety concern also, for with the long term study, they could see the safety concerns as well. So for the endometrial safety, no endometrial safety risk identified. For the hepatic safety, there is little this thing that no high law classification identified, ALT increase identified as adverse reaction. So then we can have that the liver function and ALT is getting increased, but before the studies, the baseline liver function test was not done. So the new studies are always being taken after the baseline liver enzymes, and then the patient is taken these medications, and follow up is important. A regular follow up of 1 month, 2 month, and 3 month is being given. If there is any increase, more than twofold increase in the ALT, then the patient can stop that medication, and very shortly after stopping the medication, these liver enzymes coming back to the normal. So rest other safety, so this is also safe, and the previous studies were not taking it as a the bias has not been removed, so with bias removed also safety concerns are there. Bone safety, CNS safety, and is also no risk, extra risk identified, and no drug related any thrombocytopenia, glucose intolerance, or chronic kidney disease, etc., was found. So this has been found to be an effective and with a very lower side effect profile thing. The daylight has one more study. The daylight study has assessed the efficacy and safety of fezolinetant for the treatment of moderate or severe VMS associated with menopause in individual considered unsuitable for the HT. So in particularly those patients who were unsuitable for MHT, it has been taken, and the patients of more than 40 years to less than 65 years taken. Here, the contraindicated cases for MHT, or where the patient has to be taken MHT with caution, or the stoppers of MHT, or the patients who are aversing with the MHT that we don't want to take MHT, those patients has been taken. And this study suggested that fezolinetant efficacy is very quick. And even after the first day of taking tablet, where the 7 episodes of VMS were coming, the number of episodes were significantly low even after 1 day, and after 2 to 3 days and 6 days follow-up was there. So within 1 week, there was a significant reduction in the severity as well as the number of the VMS. So neurokinin V acts via NK3 receptors on KNDY neuron, blocking that pathway, and antagonists represent the first mechanism based non hormonal therapy. What is the problem? Particularly, we are hitting on that particular problem. Few words about the comparison of fezolinetant and elinzanetant. Fezolinetant is in the markets with FDA approval since 2023, and elinzanetant got it in October 2025. So the journey of fezolinetant is longer than elinzanetant. So we know better about the fezolinetant. About the usage in various countries. So fezolinetant is approved in 40 countries and marketed currently in 19 countries, and global approval status in major countries are there, while the elinzanetant is currently marketed in being marketed in 2 countries. Now bit about the non-hormonal options once again. Like with SSRI, sedation remains the problem. They can decrease libido, dry mouth, nausea, vomiting. But when you see, so these problems are there, and when you see the net efficacy, so net efficacy is nearly 26-27%. SSRI, SNRI is also having nearly bit less range of that for the net efficacy, that is up to 23%. Anticonvulsants also giving 20 to 25%, and NK3 receptor antagonist is giving 36% result with the low withdrawal rate of 4 to 5% and with good efficacy of 66%. And yes, it is FDA approved, which is safety for ourselves also. Apart from this category, we have the FDA approval only for paroxetine. Paroxetine dosage which has been given for the approval is 7.5 milligram, which is a lesser dose. The common utility of the dose is 10 to 20, which gives usually the sedation. IMS clinical practice guideline, what does it say? You have talked about the NAPS. So, what our IMS body is saying? IMS is saying that NK3 receptor antagonists like fazolinetant, which is FDA approved, represent a non hormonal therapy for VMS, which is a grade 1, level 1 evidence, and a meta analysis of this drug with 45 milligram once daily intake was statistically significantly more effective than other non HTs in reducing frequency as well as severity of moderate to severe VMS, and showed at least comparable or superior effect on symptom severity versus most non hormonal agents. So, to summarize with the whole discussion, that 60 to 80% of the menopausal women seek healthcare due to hot flashes globally. Onset typically in perimenopause, median duration can be 2 to 5 years or more, sometimes in some patients, even up to 10 years or more. And so, exact variation we cannot say, it depends on the different category of people. An excellent opportunity to initiate preventive health services in the aging population is there for by managing VMS. Novel NK3 receptor antagonist fazolinetant and elinzanetant are the promising non-hormonal options for the treatment of moderate to severe VMS due to menopause and perimenopause. So the FDA just approved a new hormone-free treatment for hot flashes. The once-a-day pill, which will be available soon, blocks the brain chemical responsible for hot flashes and night sweats in menopause women. And thank you so much for the patient hearing. And I'm happy that my ghanti clicked on my last slide. Thank you.
Thanks, dear Jyoti. Thanks for introducing us to a newest drug, NK3 receptor antagonist, fezolinetant, which is the only FDA-approved drug in many countries for a very common symptom of menopause, VMS.
Thank
And
you.
we are waiting for it in India too.
Question and answers can be taken if few are there.
Thank you, ma'am, for the informative session.
Yeah.
But can we continue if after stopping the treatment the VMS persists, then we can restart this pizolinant or no?
Currently, the evidences are not saying it very clearly about this, sir. Yes, you are very right that current recommendations are only for the up to the 6 months. But when the medication will be in the market and it will be in the role in India, then it can be maybe taken for the longer time. And with the coming studies with our own data, we will be able to say more. And I will like to have some highlights from the Anuradha. She is from Estella. She can give us some insights about this.
Thank you, Jyoti ma'am. Thank you, Jignesh sir. So currently the data that we have, the long-term safety study that is Skylight 4 is 52 weeks of active treatment and then a follow-up treatment-free period for 3 weeks. So we have data up to 55 weeks. However, as we have seen, the effect begins as early as day 1 and since we have data till 55 weeks, I think most of the specialists that I have met going around India have said that post 3 months, I think rarely the patient continues on their own. And anyways, there is you're called back for a follow-up where you're monitoring for liver enzymes and other safety. So as long as the liver enzymes are okay and patient is finding relief, you could continue. But as ma'am rightly said, when we have the drug here, I think specialists like you who want to get into real world studies, we would have data for a longer time. The drug only has been around actually for 2 years, so we only have data till that time for now.
There is a video presentation from Mirror. Can we have that video presentation? And there is a representative from Mirror.
This was our year. We showed up
Have her on stage.
5.3 million women's health conversations across 239 cities worldwide. 95,000 plus women followed and engaged with her across our community and social media channels. Together, we built India's #1 hormonal health with 12 plus support groups across fitness, nutrition, sleep, sexual wellness, citywide survey. And the community spoke 58,000 plus real conversations. Over 3,500 women reached out with medical queries, and everyone was answered with an average response time under 17 minutes. We backed it with science. Revive, yes, and PCOS completed successful clinical trials with measurable results. Energies, memory, gut health, sleep and hot flashes, night sweats, steadier moods. Improved menstrual regularity, improvement in reproductive and ovarian function, decrease in cortisol levels. We launched 3 new products, Preserve, Try, Pivot. We also opened India's first hormone replacement therapy center of excellence. Then came recognition. Hindustan Times honored Mirror as best platform for women's health. For the third time, Mirror was the principal sponsor of Bharta Dutt, We the Women. Mirror was recognized by Forbes, Business World, Business Standard, and more. And we were seen across India on hoardings in major cities. We worked alongside the world's leading menopause experts, including doctors affiliated with the Indian Menopause Society. Through our CSR initiative, we've reached over 600 women, providing access to essential midlife health support for those who need it most. We wanted to bring all of this care, expertise, and community into one place, and that's why we created the Mirror app. That's why we're India's largest 360 degrees perimenopause and menopause care. Have you joined us yet? 2025,
I'm
this was our year.
our proud privilege to witness the learning for the most common symptom of menopause from President and Secretary General IMS. So huge round of applause for both of you.
Yeah, thank you so much, for the IMS president, Dr. Sudha Sharma and Jyoti ma'am, for giving us this opportunity wherein we were able to present our Mirror app as well. And any doctor who would be interested to know more about, how we can actually onboard you as a app doctor, please get in touch. And I'm here, and I'll definitely guide you through as well. And all your inputs are very much needed for us. Thank you so much.
Thank you, Sudha Sharma ma'am and Dr. Jyoti Jaiswal madam, for the beautiful talk. Can we have a group photo, please?
आज फोटोशूट बड़ा अच्छा हो गया पता नहीं कुछ बोला कि नहीं बोला
Thank you, ma'am. Thank you, everyone, for the group photo.
Moving ahead with our next capsule, number 17, on topic caregiver burnout in midlife women by Dr. Sandhya Dikshit. I would like to call upon Chairperson Dr. Jaya